So picture this. You're lying there doing that dreaded 3 a.m. math of how many hours you'll get if you just fall asleep right this very second. If you've been there, you are definitely not alone. Did you know that between 10 to 30% of all adults are affected by insomnia? Think about that staggering number for a second. That is millions upon millions of people waking up totally exhausted. What we're really dealing with here is, at its core, a massive, widespread engineering failure of the human body. Every single night, this highly complex biological system is supposed to power down smoothly. But for a huge chunk of the population, the system just completely crashes.
Welcome to this explainer. I'm so thrilled you're here today. We are going to treat sleep not as some mysterious, elusive state that we just have to cross our fingers and hope for, but exactly for what it is, a highly complex biological engineering problem. And you know the absolute best part about engineering problems? They can be decoded, they can be troubleshooted, and they can absolutely be solved. To fix it, we obviously need a solid roadmap. We'll start by defining the actual clinical problem, examine the mechanics of how the system fails, look at our behavioral first-line defenses, explore the full pharmacological arsenal, and finally adapt these solutions for special populations. All right, let's jump right into part 1, defining the insomnia problem. Before we can even try to fix the machine, we have to agree on what a breakdown actually looks like clinically.
Insomnia is clinically defined as having difficulty initiating or maintaining sleep, but I really want you to notice this crucial context. It occurs despite adequate opportunity. We're not talking about someone choosing to pull an all-nighter for a deadline. True insomnia isn't just about a few lost hours spent staring at the ceiling. The real defining factor is the resulting daytime impairment. The system failure at night cascades directly into functional failure during the day.
Okay, let's dive right into this. To understand the failure, we really have to understand the baseline. Think of the normal 8-hour blueprint of human sleep architecture as being divided into 2 distinct modes. About 75% of it is orthodox sleep, which includes those deep, restorative, slow-wave phases, usually happening in the first few hours. The remaining 25% is paradoxical or REM sleep, which is characterized by unsynchronized, highly active brainwaves and vivid dreams, becoming much more prominent toward the morning. Both of these are absolutely essential for your brain to function. If you deprive the system of either one, you trigger an inevitable, massive physiological rebound. So what happens when this perfectly architected blueprint systematically breaks down? Let's move over to section 2, the mechanics of a system failure.
Let's break down the 3P model. You can think of this as a sort of staircase leading straight to chronic insomnia. It starts with step 1, predisposing factors. This is your baseline vulnerability, those genetic, psychological, or biological traits that just set the stage. Then we hit step 2, precipitating factors. This is the acute system trigger. Think of a major life stressor or a sudden medical event that actually kicks off the sleep disturbance. But step 3 is the trap. Those are the perpetuating factors. Long after that initial trigger has completely faded away, our own maladaptive coping mechanisms create a devastating system lock. This is that universally frustrating experience of lying in bed, completely trapped in a cycle of your own anxiety about not being able to sleep. Which naturally leads us to the biggest question of today's explainer. How do we actually fix a broken sleep system? How do we break through that system lock and get the natural architecture back online? Well, the answer lies in the core biomechanical concept of sleep regulation. I want you to imagine your brain is a neurological seesaw. On one side, you have your wake drive, which is powered by monoamines like serotonin, histamine, and orexin. On the exact opposite side, you have the sleep drive, heavily influenced by GABA and melatonin. Treating insomnia means we literally have to tip this balance. We either need to add heavy pharmacological weight to the sleep side or actively pull weight off the wake side. It is quite literally an engineering balancing act. But hey, before we introduce any kind of chemicals to force that seesaw to tip, we always want to try a system reboot using targeted behavioral protocols first. That brings us to section 3, the first-line defense. You've probably heard the term sleep hygiene tossed around, but clinically speaking, these are not just friendly suggestions. They are incredibly strict engineering parameters. You need to establish a rigid bedtime routine, completely cut out daytime naps, ensure the bedroom is practically a cave, cool and quiet, cut off stimulants like caffeine or nicotine a solid 6 hours before bed. But perhaps the most absolutely critical tool for breaking that system lock we talked about is the 30-minute rule. Listen to this. If you can't fall asleep after 30 minutes, you have to get up and leave the bedroom. You don't go back until you are genuinely sleepy. You literally have to retrain your brain to associate the bed exclusively with sleep, not with wakeful frustration. Building right on top of those hygiene fundamentals, we have CBTI, or cognitive behavioral therapy for insomnia.
This is the critical first-line foundation of our entire treatment pyramid. Operating over a multimodal protocol of several weeks, CBTI directly attacks those perpetuating factors. And here's the crazy part. It actually produces long-lasting, highly objective improvements in sleep that are equal to, or honestly, even better than medications. All of that without a single adverse chemical side effect.
However, there are certainly times when behavioral reboots just aren't enough to tip the seesaw, often because of specific patient limitations or incredibly severe acute triggers. When that happens, we have to access Section 4, the pharmacological arsenal.
First up in our chemical toolkit, we have to compare two absolute heavy hitters, benzodiazepines and Z-drugs. Benzodiazepines, like diazepam, act like a pretty blunt instrument. They give you broad central nervous system sedation, but man, that comes with significant risks. Things like ataxia, respiratory depression, and even amnesia. On the flip side, we have Z-drugs, like zolpidem. These offer much more selective binding. They have a shorter duration, which is awesome for dodging that next-day grogginess, but they carry their own distinct and, frankly, bizarre risks. We're talking about complex sleep behaviors, like sleepwalking, or even cooking a full meal while completely unconscious.
Now, what's really fascinating here is exactly how both of these drug classes interact with our seesaw. They are both GABA-A modulators. By binding to these receptors, they pop open chloride channels, hyperpolarize the neuron, and actively shut down arousal centers. In plain English, they drop a ton of pharmacological weight directly onto the sleep side of the seesaw. But you cannot ignore that severe black box warning. All Z-drugs carry a very strict warning for those complex behaviors carried out while you're not fully awake.
Moving deeper into the arsenal, we have tools that target the chronobiotic clock, specifically the melatonin systems. Unlike the heavy, blunt sedation of those GABA modulators, you can think of these as precision dials used to sync your biological clock. Melatonin is a naturally occurring hormone controlled by light and dark cycles. But a quick warning here. Over-the-counter supplements can have massive, totally unpredictable variations in their actual dosage. Then you have Ramelteon, which is a highly selective receptor agonist that safely improves sleep onset, even for older adults, without enforcing that heavy, broad sedation. But what if, instead of pushing the sleep side down, we target the other side? Here's a total strategic flip in the approach. Dual orexin receptor antagonists, or DORAs, like suvorexant, work by neutralizing the wake signal entirely. They literally block the wake-promoting orexin neuropeptides from binding to their receptors. So rather than forcing your brain to sleep, they selectively lift the weight off your brain's wake drive.
Finally, we have these sedative antidepressants. Now with these, dosage is absolutely everything. Doxepin, for instance, is FDA approved for insomnia, but only at precision microdoses of just 3 to 6 milligrams. At that tiny dose, it acts purely as a highly selective histamine receptor antagonist to maintain sleep safely. Contrast that with trazodone. If you've ever been prescribed trazodone, it's pretty crucial to know that while it's widely prescribed off-label for sleep at massive doses of 50 to 150 milligrams, clinical guidelines actually push back on making that a routine go-to, mostly due to sparse efficacy data and real risks of next morning memory deficits.
If we map out our entire pharmacological arsenal into a matrix, you get the ultimate visual summary of what we're working with. Whether we are modulating GABA with benzos and Z-drugs, antagonizing orexin with DORAs, blocking histamine with microdosed antidepressants, or syncing up the circadian rhythm with melatonin agonists, every single one of these classes manipulates the biological system in a very specific, calculated way. It's all about choosing the absolute right tool for the specific mechanical failure at hand.
And let me tell you, choosing the right tool becomes exponentially more critical when we start dealing with real-world system constraints. Let's head into our final section, adapting for special populations. And this brilliantly illustrates exactly why biological hardware constraints matter. Look at the massive disparity in the clearance rates between men and women for a drug like zolpidem. Back in 2013, the FDA actually had to step in and require manufacturers to lower the recommended dose for women. Why? Because women have a significantly slower clearance rate for this specific drug. Up to 15% of women still had plasma levels high enough to dangerously impair their driving ability a full 8 hours after taking it. We simply cannot apply a one-size-fits-all engineering solution when the underlying biological hardware processes chemicals at completely different speeds. When we build an algorithmic decision map, it shows the extremely careful adjustments we have to make for our most vulnerable populations.
For pregnant patients, untreated poor sleep is dangerous, for sure, but benzos and Z-drugs are totally contraindicated because of birth risks. The adjusted intervention? Sedating antihistamines like diphenhydramine. For elderly patients over 65, the biggest risk is polypharmacy and devastating falls, so we avoid heavy sedatives entirely and shift to onset interventions like Ramelteon or maintenance tools like low-dose doxepin. We want to safely restore the sleep architecture without causing any daytime instability.
We've covered a tremendous amount of ground today, from behavioral reboots all the way to molecular antagonists. But the overarching takeaway from this entire explainer is simply this. Insomnia is an engineering problem that we can actually solve. It is not some mysterious, permanent curse hanging over your head. It's a mechanical imbalance of biological drives and behavioral habits that can be systematically assessed, accurately targeted, and effectively corrected.
So I want to leave you with this final, provocative thought to evaluate in your own life tonight. When you look at your daily habits and your nightly wind-down routine, are you actively reinforcing a maladaptive system lock, or are you taking the behavioral and environmental steps necessary to tip that neurological seesaw back into perfect, restful balance? Thank you so much for exploring the mechanics of sleep with me today. Keep learning and keep balancing the system.